Team for Dementia is a project initially funded by Department of Health, Office of Life Sciences at Department of Health, and for the past year has been funded by NHS England. We started around 3 years ago and focuses on improving care and providing in-home care using sensory technologies and machine learning. Dementia affects something around close to 900,000 people in the UK. At any given time, it's around 1 in 4 hospital beds in the UK are occupied by someone with dementia. In fact, within the next 15 minutes I'm going to speak, around 5 people in the UK will be diagnosed by dementia, 1 every 3 minutes. The current care system is depending on which part of the country someone lives. They will visit a neurologist or most of the time a psychiatrist. They're referred by the GP to see a specialist, and a specialist will make a diagnosis, and people will be giving some information, what in the clinical setting we call it signposting, and they are sent home. Most of the time, people won't see their clinician or won't see their GP until a crisis happens. And in some parts of the country, also there is huge disparity in accessing people, or how much people actually access to the primary care or secondary care when they are diagnosed with dementia. This map shows the the people with dementia who visited their GP over the past 12 months. The lighter shades of blue shows the less visits and less access to the healthcare. And there are areas, for example, in parts of the country which people with dementia, around 50% of them, they haven't seen their GP over the past 12 months. In this project, what we're trying to do, our study started with assumption, can we use low-cost sensors? First, we wanted to make something which is accessible, not really creating a complex technological system, but looking at the low-cost and available in-home sensory devices, and to see if we can help people with dementia to live safer, with better quality of life and longer in their home environment, and provide care support to the carers and reduce the hospital admissions. What I forgot to say, Alzheimer's Society a few years ago did a study and looked at the hospital admissions in people with dementia, and they concluded around 22% of the hospital admissions in people with dementia are due to preventable causes. We try to focus on that gap and try to see if we can use some of the information we can collect from the home environment, combining environmental data and physiological data, if we can make identifying some of those risks earlier or more predictable. We deployed 2 classes of devices in people's homes. First set are physiological devices. Most of these devices are widely available. The only difference here are they are pre-programmed and they are connectable, and the people start measuring the information directly. It's relayed back to our servers. Obviously, we have all the security and privacy mechanisms in place. And then people get the technology, they get also training how to use it. And the idea is the physiological devices, we don't use many wearables. In fact, we don't use any wearables devices. And the idea is the patients themselves or the carers will help them to once or twice a day to monitor their physiological signals. And we have a lot of sensors which are blended into the environment. They monitor people's movement. When someone sits on a sofa, we have a pressure sensor. For example, a pressure sensor detects if someone's sitting on a sofa. When people sleep on a bed, the bed mats, which detect by looking at the pressure, looking at if someone is sleeping. Or if they are switched on a kettle, for example, we have plugs which they detect if the kettle is on, and you can monitor different activities and different use of home appliances around the house. In a complex form, when we started this project, we had around 80 companies, 80 technology companies applied to join this project. Through different phases, we narrowed it down to 10 companies. And on purpose, we chose companies providing technologies which were overlapping. Like if you were getting a blood pressure or, I don't know, environmental monitoring sensors, we had different providers of that device. The reason for that was we didn't know what is going to work. We didn't know what type of devices our patients are going to like. And also we didn't have a really gold standard to monitor and find a baseline which devices are more accurate or more reliable in terms of in long-term use, in terms of the battery, in terms of reliability and calibration over time. The problem is, as soon as you start getting like a device, you have an app. You get the next device, you have the second app. You add another device, you have another app, and you end up looking at the multiple interfaces. One of the first bases for our technology partners to join this project was to have open APIs. That meant we created a common language. It's just a metadata model which annotates our data. It's a common language representing all the data we get from the devices. And that model is compatible to FHIR and HL7 standards, which we can later on integrate it into primary and secondary care dataset. That means it doesn't mean for our system whether you're getting the blood pressure data from company A's device or company B's device, what type of device you're using. And in future, if a better device comes to the market, we can just plug it and the system will detect it. And all the algorithms are designed to use the blood pressure data, still can work with that. Once we had this common language, we created some infrastructure to be able to integrate this data. Obviously, we are creating, we are collecting a patient and quite sensitive data. We needed to create all this randomization, all the encrypted channels, encrypt the data, and create failover system. Because once the system is up and running, you are monitoring people, and you need to make sure your downtime is close to zero. The most interesting part of the system in terms of the technology is using machines to do the repetitive task. But that's interesting, but it's not important. The most important part of it is how actually you integrate the data you collect to a clinical setting and how you allow your clinicians to make decisions. We started creating a software. This is designed from scratch. We created a bespoke software which looks at each home or each participant appears like a card. And the homes are monitored in 3 categories, based on technology, environmental, and clinical data. The idea is if you're using devices to monitor people with dementia and their carers in their home environment, you need to make sure those devices, they function. Then there are simple algorithms they monitor and they make sure the batteries are not running out of, the devices don't run out of battery, they are sending their information. We have some algorithms looking at very basic data, looking at temperature data, let's say carbon monoxide leak, and this type of information to make sure everything around the environment it seems okay. But there are a set of algorithms which combine environmental and physiological data we collect to create more, we call it actionable information to help our clinicians. And the system is dynamic. It works based on alerts. The idea is our clinicians, they don't need to continuously look at this data and graph, which you see in most of the systems. And the idea is they process the information, they do the repetitive task, and when it's something important for our clinicians to look at, they will generate an alert. At the same time, we have all the provenance data, all the background data. If our clinicians, they want to see the data, they can go and look at it, and they can create graphs. If you are looking at someone's blood pressure, you can look at for the past 2 months. And now we have created an app, one of our technology partners has created an app which patients can take that and show it to their GP or use it when they go to hospital. But the system will, once there is an alert, will create an interface like this, will show the information to our clinicians. And the idea is the clinicians will look at the aggregated information and the information which machine learning algorithms generate and will respond to the alerts. And the system has several options to allow them to follow up the alerts, to work between shifts, because we, initially when the phase 1 of the trial, we providing 24/7 services. Then but once you're responding to an alert, you want to follow up and see what has happened. The algorithms analyze this data. They work on, some of them they work on very simple but interesting statistical principles. For example, when we collect the vital signals, the algorithms, they learn what are the mean and standard deviations. It's not very difficult in terms of algorithmically develop this. But then you can create personalized algorithms. Let's say if I'm on the upper boundary of a blood pressure, the system learns what is my norm, and it starts looking at the changes in my norm and personalizes the alerts, and you can obviously change and calibrate those. You have some absolute minimums and maximums which you generate alert no matter what, and then your algorithm learns where someone is and starts looking at the shifts to left and right based on that data. We have developed some algorithms. They are looking more complex information. One of the early algorithms we created was looking at the agitation, aggression, and irritability. We looked at, I'll explain how it actually works, how we can combine physiological and environmental data to look at some of the behavioral changes in people who are participating in this study. We have also created algorithms looking at environmental data and monitoring the changes in the trend of activities. One of the algorithms looks at UTI and detects the risk of UTI. I was very skeptical we can do something like this, but it turns out it works to certain accuracy. UTI, urinary tract infections, are one of the top 5 reasons in people with dementia to be admitted to hospital. If it's detected early, it can be treated with antibiotics, but once it becomes more advanced, it's very difficult because it comes with symptoms like delirium. And in people with dementia, it gets mixed up with their cognitive condition. And every time they are admitted to hospital, also affects their cognitive capabilities. There are lots of studies that are showing the link between, like when people really get advanced infections, go to hospital, and then they come back, their cognitive function declines.
Okay, nearly here.
Oh, okay, then I will be very quick. The machine learning algorithms, the way they work, the first algorithm looks at analyzing the patterns. If I do all the activities the same time, these are the days of the week and these are the times of the week. If I do the same activities the same time every single day, you will see something like the same colors. Each color represents an activity. Let's say this is sleeping, making a cup of tea, going and sitting on a sofa, and so on. This data comes from a real, from a real patient. And you see there is a level of, there's a lot of randomness in what people do. What our algorithms are interested in looking at each of these individual markers, now have separated each of those activities, like looking at the walking in the PIR stands for passive infrared. It means there are sensors monitoring movement. And all of our algorithms, what we do, we are looking at, for example, if I wake up and go and switch on a kettle and make a cup of tea, that information, we read it, and we read what time I did it. And then if I go and sit on a sofa, our sensors detect the pressure, and I know someone is sitting on a sofa. I learn what is the probability after someone, when I say, machines do that, when the machines, they learn, when someone makes a cup of tea, what is the probability of them going and sitting on a sofa, going back to the bedroom, going and opening, the back garden. And the machines, they learn the transitional probability. And we monitor people for around 60 days to allow algorithms to learn. This is a way of teaching machines by experience. We give them enough experience and enough data to learn. Once they learn those the transitions, we give them 2 weeks to learn how much people deviate from that activity. Usually people won't do exactly the same thing every single day. Once the machines have been trained, and they have been trained also to see how much people deviate, we leave them to start now observing. Let's say if whenever I woke up and made my cup of tea, 80% of the time I went and sat on a sofa, 20% of the time I went back to the bedroom. If I never opened the front door to leave the house, we are measuring that the machine will be surprised because it has never seen that. And we are measuring the level of surprise or entropy in our system. And that entropy will give us some idea to how actually people get either hyperactive or totally less active, which can be effects like social isolation or affect their health and well-being. The UTI algorithm looks at a number of times people go to bathroom, looks at their sleep pattern, their movement pattern. It turns out if I have a UTI, the number of times I go to bathroom will increase, my sleep patterns will change, my movement patterns will change, my body temperature will slightly be higher. We collect all that and we feed it to a machine learning algorithm which detects the risk of UTI. The first phase, we were very detective. We were looking at the information we were trying to detect, but the more and more we collect data, we become more preventative. My time is up. I'll show just a very short video from Phil and June, which are... No? Okay. Okay, I'll stop here. Thank you very much.